So now, today I'm going to explain the pulp therapy in young, permanent, and in primary teeth. First of all, we begin that the pulp exposures, which are due to caries, are more common in primary teeth than in permanent teeth. What are the reasons? They have more prominent pulp horns, especially in the mesial pulp horns. They have thinner enamel and dentine. The enamel thickness is 1 millimeter all around. The larger pulp chambers and the proximal caries, which involves pulp in 85% of the cases with broken marginal ridges. So these are the three reasons. They have more prominent pulp horns, thinner enamel dentine, larger pulp chambers. So the primary objective of pulp therapy is to maintain the integrity and health of the teeth and their supporting tissues. So the indications, objectives, and type of pulp therapy depends on whether the pulp is vital or non-vital, because the therapy differs in vital and in non-vital. So the pulp situation can be classified into either we have the normal pulp, which is responsive to vitality retesting. We have the reversible pulpitis, which is capable of healing. And we have the irreversible pulpitis. The vital, we have here a vital inflamed pulp, which is incapable of healing. And fourth, we have a necrotic pulp. So the pulp therapy differs in every pulp situation. So to conduct a correct treatment plan, we have to conduct a correct diagnosis. So what is contained in a correct diagnosis? We have we take first the medical history, then the past and present dental history, and we look at the treatment and chief complaint. This is mainly in children pain. Subjective evaluation of the area. Objective extraoral and intraoral. Here, the L is here, intraoral soft and hard tissues. Then we take X-rays to diagnose the periapical and periradicular changes. Then we do clinical tests, palpation, percussion, mobility, and just to know as a hint is that electric pulp and thermal tests, they're unreliable in immature, permanent, and primary teeth. So it is better to avoid it when you diagnose a child. So the medical history. The medical history, of course, affects the type of treatment. As in certain systemic diseases such as cyclic neutropenia, leukemia, nephritis, and cardiac affection, it does affect the treatment. And the extraction of affected tooth with proper medication would be the correct choice. So this is actually the first thing, medical history. And then we have the past and present dental history. This topic indicates the child behavior and dental hygiene. So as we said, there are like many pulp situations. In the reversible pulpitis here first, we have a momentary sharp pain for seconds. Okay, and in the irreversible pulpitis, it is spontaneously. The pain is spontaneously continues. The patient awakens by night. Then we have the third. We have the evaluation of the chief complaint. It is mainly pain, as I said. It is not fully reliable in children because the child can say something completely different, and at the end, the diagnosis is something else. The teeth characterized by provoked pain of short duration, relieved by analgesics, or upon removal of stimulus is the reversible pulpitis. So it is just, again, I talk about here the reversible pulpitis and the irreversible pulpitis. We have said here that the reversible pulpitis with a sharp pain for seconds. That means that if we remove the stimulus, for example, toothbrushing, the stimulus disappears. So this is a reversible pulpitis, and we need here a vital pulp therapy. Okay, in irreversible pulpitis, where the pain is spontaneously continues and patient awakens, and we have sometimes swelling too. We need the non-vital pulp therapy. So, fourth, we have the extraoral and intraoral clinical examination. We do the soft tissue examination. We can see sometimes they have the child has swollen inflamed tissue. Severe cases may manifest cellulitis. It is like an extraoral swelling of the cheeks. Pulpal necrosis manifests changes in soft tissues. And any of these signs indicate irreversible state of the pulp that require non-vital pulp therapy. So then we do the hard tissue examination. We look if there's any deep caries, broken marginal ridge, pulp polyp appearing from the pulp chamber of affected tooth. So here there's letter missing. Sorry. So then we have the radiographic examination. The X-ray is really important because we have here a child with primary teeth that may be resorbed in the roots due to the eruption of the permanent teeth. So the interradicular area is the first area to check in primary teeth. Due to numerous number of lateral canals and ramifications that are present in the frication area, which allows the insult from any chronic cardiogenic bacteria present to dissipate into the surrounding periodontium, primarily throughout the frication area prior to the periapical area. So the frication area is really, really important. This is the first area where bacteria can dissipate and start its action. So, thus, any radiolucency in this area dictates an irreversible pulpal status that required non-vital pulp therapy. Sometimes it is misleading because the young permanent teeth roots are not yet completely formed. So that's why the dentist has to know what age, what stage, and the child has reached, and the X-ray of a child is not always reliable. If we have a pathological bone resorption, which may indicate widespread of infection due to pulpal necrosis and irreversibly inflamed pulp, care should be taken with primary dentition as radiolucency in bone may be normal and associated with development of successor tooth. And radiolucency is more common in frication area due to accessory root canals. So this might indicate an irreversible pulp damage. So, if we have an external root resorption, this also indicates non-vital pulp therapy. Indicates prolonged infection. No pulp therapy or an extraction might be the right treatment unless the tooth is strategic. So the break of the marginal ridge indicates a high incidence of exposure. And we have here, we have talked here about the external root resorption. But what is if we have an internal root resorption? This also indicates like irreversible inflamed pulp It indicates an advanced degeneration in pulp, and non-vital pulp therapy can be conducted in an attempt to stop the resorption process. Yeah, if we have isocalcific mast globules, we have a non-vital pulp therapy. So, other clinical tests, for example, mobility, may be valuable with radiographic evidence to denote the difference whether it's physiologic or pathologic root resorption. The primary teeth mobility can be physiologic or pathologic, both diagnosed by age and X-ray. So the physiologic mobility is normal mobility during shedding, and the pathologic mobility, grade 1, 2, and 3, indicates that the pulp is irreversible inflamed, which needs then a non-vital pulpal therapy. Percussion. The percussion is done by finger tapping. The pain on percussion indicates irreversibly inflamed pulp, and it is better with older children. With younger children, as they move a lot, it cannot be that reliable. And the children might be afraid from it, and it can give false positive or negative results. Pulp tests. For primary teeth, the vital tests are not dependable, not reliable. For permanent teeth, the electric pulp testing are particularly valuable for fully formed tooth. It's really important for fully formed tooth, but not for partially developed tooth, okay? And hot and cold tests are also valuable. So, now we have talked about the diagnosis, about how to do a correct diagnosis. Now we talk about the various pulp therapy treatment modalities in primary and young permanent teeth. So, first we talk about the reversible inflamed pulp. One therapy type is the indirect pulp capping. So, when is indirect pulp capping done? Does it perform in teeth with deep carious lesion without evidence of radicular pathology? And the indirect pulp treatment is a procedure that leaves the deepest caries adjacent to the pulp undisturbed in an attempt to avoid pulp exposure. The caries affect the dentine, covered with bicompatible material to produce a biological seal. We put like radioepic liners such as dentine bonding agent, resin modified glass ionomer, calcium hydroxide, and MTA. Glass ionomer provides sealing, full staccato rest to prevent microleakage. So just to imagine, here's like the tooth, okay? And then what we have here, okay, it is like much deeper, okay? Here's the caries. This is the caries here. And a part of that caries, we leave it behind. We leave it on the dentine, okay? And then we put like biocompatible material to produce like a seal. And this can be a dentine bonding agent, resin modified glass ionomer, calcium hydroxide, MTA. Then on it, we put the glass ionomer, okay, to prevent like any microleakage. So we have here the caries affected dentine. So then the tooth is followed 6 to 8 weeks. We look at the dentine bridge or a dentine bridge we look at the dentine bridge which is formed. Then we seal it with a crown. The re-entry and remove the last caries present. There are like two alternatives. Either you leave the dentine bridge, which is formed, or you do a re-entry and you remove the last caries, which is present after the dentine bridge, and the tooth is then restored. So you have two things: dentine bridge, or you just leave it, or you do the re-entry. We have talked about the indirect pulp capping. Now we talk about the direct pulp capping in young permanent teeth now. So because the direct pulp capping, they're not preferred in primary molars with caries exposures. When we have a pinpoint exposure, 1 millimeter or less, we put like a biocompatible radiopaque base, such as MTA, calcium hydroxide, which is placed in the exposed pulp tissue. Then the tooth is then restored with material that seals the tooth, to prevent any microleakage. So actually, the steps are quite equal with the indirect pulp capping, but the thing is here that that we don't leave any caries. We don't leave any caries. This is like a direct pulp capping where you put a radiopaque base as MTA or calcium hydroxide. Then after that, we put the glass ionomer. We also follow it up for 6 to 8 weeks and see the outcome. Indications for vital pulp, of course, for young permanent teeth, especially for the sixes and upper and lower anteriors. So the direct pulp capping is better to use it for primary molars. It is not preferred to do it in primary molars. It is preferred to do it in permanent teeth. Yeah. So the success of primary teeth with caries pulp exposure is highly dependent on conduction of procedure under strict isolation measures. So actually, some say we can do it. We can do the direct pulp capping on primary teeth, but we need a direct and strict isolation, and it can lead to failures. So just better to avoid that step. So the pulpotomy in primary teeth. What is the actual pulpotomy? And pulpotomy is the removal of inflamed coronal pulp tissue. People do confuse it with pulpectomy. Pulpotomy is the removal of the inflamed coronal pulp. Pulpectomy is the removal of the coronal and the radicular pulp. So till the orifice by sharp excavator or large round burr. So the coronal pulp is amputated. Then we see pulpal hemorrhage, controlled by moist, sterile cotton pallet under pressure for 5 minutes. Then the remaining vital radical pulp tissue is then covered with MTA in the form of cresol. So, what are the steps of pulpotomy? First, we give anesthesia, we do the isolation, we do the excavation. Then we do the de-roofing, which is very important, of pulp chambers by large round burr. Then we do the perp laterally. We put like the perp laterally on the walls just to check just to check the de-roofing. Then we do the hemostasis by moist cotton pallets. We put MTA then, or formicresol, seal the cavity. Then we dress the material as zinc oxide and eugenol. And then put the base material as a glass ionomer. And then we put the stainless steel crown usually. So these are the steps. Formicresol, you might hear it. Formicresol is a gold standard material as medicament in deciduous teeth. The success rate to use formicresol in pulpotomy is 70 to 98%. It consists of 9% formaldehyde, 35% cresol, and 15% glycerine and water, which is called also Buckley's formula. So if you have it like in an exam, Buckley's formula, this is this might talk about the formicresol. So the mode of action of formicrosol is it fixates or fixes the pulp, the cornal third of the root, and the middle third presents loss of cellular integrity, and the apical third shows vital granulation tissue growth. So the formicrosol is used in the cornal third, okay. We have a middle third and an apical third, which shows different different areas. So the formicrosol burns the tissues applied only in the exposure side. After pulp tissue removal, and this kept for 5 minutes, then the blood becomes dark red brown, and the pulp fixation resolves. So the formicrosol has been used. We can also use MTA. Okay, so this is like put like for 5 minutes, and then you see the blood changes its color to dark red or brown, and yeah. So the contraindications of using pulpotomy is in immunocompromised patients, of course, patients at risk of bacterial sepsis, history of spontaneous pain, which might lead to which might indicate irreversible pulpitis, presence of swelling, excessive bleeding from root canals, which cannot be controlled with cotton pellets. We have pulpal blood that's extremely dark colored in case of any sign of unvitality. So the color of the blood can also indicate a sign of unvitality. Then there are two types of formicrosol pulpotomy. We have the single visit and the 2-visit pulpotomy. Just to know, from now, it is there are no big differences between them. The single visit has been used for vital primary teeth, and 2-visit pulpotomy for vital and non-vital primary teeth. So what are the indications, or when do you do the 2-visit pulpotomy? If you fail to obtain a propofol anesthesia due to pulpal inflammation, and if you have an uncooperative child, or if you're unable to arrest the hemorrhage, which can indicate pus abscess, any signs of non-vitality. So, the difference between the both pulpotomy visits, the first and second visit, is that you put the cotton pellet with formicrosol for 7 till 10 days, covered by temporary filling. Okay. And this is like now for the second visit, that you put in between the first and second visit the formicrosol. And then if the child comes for the second visit, you do the reassessment. And if there are no signs and symptoms, you do the same steps of the single visit pulpotomy. Okay, you put the MTA formicrosol, and then you put like the base material glass ionomer, and then you seal it, then you cover it with stainless steel crown. Of course, the placement of zinc oxide and trigonal, followed by stainless steel crown as a final restoration. Not forgetting here, the MTA seal the cavity, the dressing, the zinc oxide original, base material as glass ionomer, and the stainless steel crown. Yes. Then, the non-vital pulp therapy treatment modalities. So what is if you do a lesion sterilization tissue repair in primary teeth? What is it actually? What is actual lesion sterilization tissue repair? It uses no instrument for the root canals. We have an antibiotic mixture, a thermal antibiotic paste, which is placed in the pulp chamber, which disinfects the root canals. And after opening through the antibiotic paste, you enlarge the corneal canal orifices using a large round burr to create medication receptacles. And then these chamber walls are cleaned with phosphoric acid, which are rinsed and dried. The paste, antibiotic paste, consists of clindamycin, metronidazole, and ciprofloxacin. They're combined with liquid vector of polyethylene glycol and macrogol. And to form the paste, and the paste actually, which is placed then directly into the medication receptacles and over the pulp floor, which is then covered with glass ionomer cement, then restored with stainless steel crown. And the aim of this antibiotic is just to resolve the infection in canals, and not using any instrument. This might be an advantage too. So, pulpectomy. We have now talked about the pulpotomy. Now, pulpectomy is the removal of pulp tissues in both coronal and roots radicular portion. After the canal's dried, we put like resorbable material such as non-reinforced zinc oxide eugenol, which fills the canals. Then exactly the same thing, restored with a stainless steel crown, and we evaluated every 12 months. So, what are the reasons why we do pulpectomy? To remove irreversible inflamed radicular pulp, and to obturate the root canals with filling material. They resorb the same rate as a primary tooth, and can be eliminated rapidly if accidentally extruded throughout the apex. So this is quite a good advantage. Here is a table. The difference between pulpotomy and pulpectomy. The first 4 steps are quite the same. Then from the 5th point, you clean the canals here with edge files. Okay, with edge files, and you don't use any gutta perca because a root resorption occurred due to the permanent teeth. Okay, and then you reuse the saline or chlorhexidine irrigation, and avoid sodium hypochlorite accident, please. So the pulpotomy is what I have said: anesthesia, isolation, excavation, and so on. This is a good table just to have a look on it, to see the difference between them. As the pulpectomy can be performed in the single visit. We have talked about pulpotomy and pulpectomy as a single visit for the most primary teeth, but multiple visit here is done when you have a mobile tooth, abscess, pus, and canals. So the contraindications of pulpectomy, again, immunocompromised patients, risk of bacterial sepsis. If the X-ray indicates a pathological advanced root resorption and a very high mobility, it is then not good, contraindicated to do a pulpectomy. The pulp therapy in young permanent teeth aims to facilitate the natural completion of root through apexogenesis. This is something else. I've talked about the primary teeth, and the permanent teeth have something different. The apexogenesis, which is like a physiological root development, This is actually the last slide. I hope you understood my presentation, and if you have any question, please write it down in the comment. I'll be glad to answer your questions, and till the next video.